everybody to our afternoon session, the West Yorkshire Integrated Care Board. My name is Nader Mirza and I'm the acting chair. Very warm welcome to those of you who might be viewing us or joining us online on stream. A very warm welcome to all of you observing, and we recognize that this meeting is held in public, but it's not actually a public meeting. There is an opportunity shortly for public questions on items on the agenda. And please can we ask that you don't film or take photos during the meeting due to the need to respect the privacy of those who are here watching. We do live stream on our website and share photos via our social media should you wish to use these, and we ensure that the necessary consent is in place to do this. So before we start, if we could just go around the room and introduce ourselves, who we are and where we're working. If I start with Bev.
Good afternoon, my name is Bev Geary. I'm Director of Nursing for West Yorkshire ICB.
Afternoon, Vicky Dutchburn, Interim Accountable Officer for Kirklees Place.
Hi, I'm Karen Jackson. I'm the Chief Exec at Locala and the Sector Lead for Community Services.
Hi, Tim Riley, Accountable Officer for Leeds Place.
Hello, I'm James Thomas. I'm the Medical Director for the West Yorkshire Integrated Care Board.
Therese Patton, Chief Exec, Bradford District Care Trust and Place Lead for Bradford District and Craven.
Hello, I'm Brendan Brown. I'm the Chief Executive at Calderdale and Huddersfield Foundation Trust and the Acute Sector Lead for the board.
Hi, I'm Hannah Davis from Healthwatch Leeds. I'm here on behalf of the 6 local Healthwatch working across West Yorkshire.
Hello, I'm Kate Sims. I'm the Director of People for the ICB.
Hi, Amy Willett, Head of Corporate Governance for the ICB.
Hello, I'm Laura Ellis. I'm the ICB's Director of Corporate Affairs.
Hello, my name's Rob. I'm the Chief Executive.
Hi everyone, Ian Holmes, Director of Strategy and Partnerships and Deputy Chief Executive.
And hi everyone, I'm Adrian North. I'm the Deputy Director of Finance for the ICB.
Good afternoon, Lou Auger. I'm the Interim Director for Planning and Performance for the ICB.
Good afternoon everyone, Matthew Desane, one of the non-exec members.
Good afternoon, Jane Madeley, also a non-exec member and Chair of the Audit Committee.
Good afternoon, Mel Brown, Interim Accountable Officer for Wakefield Place.
Hello, Kim Shutler, VCSE Sector Lead.
Good afternoon everyone, my name is Shaukat Ali Khan. I am the Chief Digital and Information Officer for the West Yorkshire ICB.
Good afternoon, I'm Deborah Harkins, Director of Public Health for Calderdale and representing the West Yorkshire Directors of Public Health.
Rachel Loftus from Local Government, deputising for Ed Whiting.
Keir Shilliker, Programme Director for Mental Health, Learning Disability and Autism, here for Sarah Munro.
Hello, my name is Fatima Khan Shah and I'm proud to be the West Yorkshire Inclusivity Champion.
Welcome everybody and thank you. I'm going to pass over to Laura Ellis who will read out the apologies and people who are going to have to leave early.
Thank you. Yes, please just bear with me. We do have quite a few apologies and deputies this afternoon. So we have apologies from Robin Tuddenham, Victoria Eaton and Deborah Harkins is deputising, Sarah Munro and Keir Shilliker is deputising, Richard Vaughtry, Jonathan Webb and Adrian North is deputising, Anthony Keeley, AC, Councillor Tim Swift, Ed Whiting and Rachel Loftus is deputising and will be leaving at around 4 o'clock. And then we also have 3 others who will be leaving a little bit early. So Fatima Khan Shah is leaving at 3:45, Shaukat Ali Khan is leaving at 4 and Mel Brown is leaving at about 4:40. Thank you.
Okay, thank you, Laura. Our next item is declaration of interest. I'll ask members to declare any interests relevant to today's agenda. Thank you, Teresa.
Chair, so item 24, the Joint Capital Resource Plan, there is a suggestion that my organisation, Bradford District Care, has an additional amount given to it.
Okay, thank you. Well, throughout the meeting, reference will be made to organisational change, and it is recognised that all members of the board should declare a direct financial and professional interest in this. Okay, thank you. Oh, Jane.
Yep. Just to mention, under your chair's report in section 411, it talks about the extension of mine and others' contracts in terms of our roles on the board.
Okay, thank you. The next item is the urgent decisions. There have been 2 decisions taken under the urgent decision process. Oh, I beg your pardon. My eagerness to go through this wonderful agenda today. Thank you. Let me take the minutes of the last committee meeting, board meeting. Can I take them as a correct record? Yes, thank you. Any matters arising that are not on the agenda or not on the action log? No? Okay. Laura, would you like to take us through the action log, if there are any outstanding items?
Thank you. Yes, I think the first one is not yet due in respect to the digital strategy. And then I don't know, Fatima, if you wanted to give an update on the joint work with the combined authority. I think you were going to circulate a report following the last meeting.
So it's a very, very exciting time at the moment for our work in partnership with the Combined Authority. We've had a recent meeting of the Joint Work and Health Board, which is evolving into a strategic aspiration, which is called Healthier Lives. The report that I wanted to circulate, Chair, hasn't been circulated as yet because we're awaiting the formal governance, which I think was approved at the Combined Authority meeting last Thursday, to approve some formal governance for us to meet as a partnership-wide board. So there'll be representatives from both the ICB and the Combined Authority and elected members. So once that's been approved, I'll circulate the report then, and my apologies with the delay in completing that action.
Okay, thank you, Fatima. Is that it, Laura? Yeah. Okay, so now we're up to the urgent decision. There have been 2 decisions taken under the urgent decision process, and we are required to bring these for ratification to our board. Laura, could you outline these, please?
I can do. Sorry, apologies, I'm moving between different papers. Yes, so the first one, the first one relates. Apologies because I get an echo in between the 2 microphones. The first one relates to a change to the ICB constitution, the standing orders specifically, to enable us to extend appointments to the board. So that's been brought for ratification. Today the full details are within the urgent decision notice. And the second one relates to confirming the acting chair arrangements before the end of May. And again, it's for ratification today, and all the details are within the decision notice.
Okay, so the ICB board is being asked to formally ratify those urgent decisions. Okay, approved. Thank you. I believe we have one question from the public. Laura, if you'd like to read that out.
Thank you. Yes, we have received one question from Alistair Bailey. I'll read that out and then I'll pass to James Thomas to respond. So the question is, the NHS 2025-26 priorities and operational planning guidance asked integrated care systems to optimise medicines value and improve the adoption of and compliance with best value NHS supply chain frameworks in medicine and procurement. Which NHS supply chain frameworks will the ICB be prioritising to show projected savings to implement the planning guidance? And I'll pass to James, thanks.
Okay, thanks, Laura. So I can confirm that the ICB intends to adopt and comply with the national frameworks as outlined in the 25-26 NHS priorities and operational planning guidance. In terms of particularly around the prioritisation of the NHS supply chain frameworks, the ICB will continue to adopt the frameworks from the NHS medicines procurement and supply chain where appropriate, and work to deliver the best value procurement we can, as we would expect. Thank you.
Thank you. Thank you, James. That was our one and only question for this afternoon. Can I just remind everybody who's watching in particular that individuals are always welcome to contact the ICB, and there is further information on our website for public inquiries. The opportunity to submit freedom of information requests or seek assistance through our complaints and PALS, which is our patient and liaison services. Complaints or questions are really welcomed, mainly because it helps us improve our services and do what's right for our patients and our public. So thank you. Okay, we're on to the 15th item, which is around the reflections on themes from the Health Inequalities Focus on sessions. We had asked Health Watch West Yorkshire to undertake a review of the focus group sessions that they'd developed for us. And I'd like to invite Hannah Davies to take us through the review and her main findings. We do have a paper in our bundle here, so key themes would be really good to hear.
Great, thank you, Nadra, and for the opportunity to reflect and consider this past year of ICB Focus On sessions. In those sessions, we've highlighted people's experience of health and care in West Yorkshire, with a focus on those experiencing or at risk of health inequalities. And many thanks to all those people who've spoken with either the local Health Watch or with fellow voice partners. We greatly appreciate you sharing your insight and hope we can demonstrate how that's being acted upon. At this important time in NHS and care planning and setting the future direction, it feels like a really important time just to reflect on what people have been telling us. The work that we wanted to do was just to reflect on those consistent messages. It's been a key reflection point for many of our board members around there are consistent messages that we're hearing in people's experience, and how do we focus on those? Just to remind you, over this past year, we've looked at the experiences of children and young people, working age adults, older people, and maternity experiences, all with a focus on people at risk of health inequalities. And within each of those reports, we've made a series of recommendations. How those recommendations are used is something that we're really keen to explore as we go into that next stage of the ICB, and how they're used locally within local places. And if people would like to see those, I'm sure that there's links in the pack, but also they're on the Health Watch website, or the local Health Watch website. We did do some presentation slides for this, which hopefully people have had the opportunity to look at, but I'll just talk you through some of those headlines. And I suppose what's really positive is hopefully they'll all be able to reflect on those with the conversations that we have over the course of this afternoon. So the first one, in terms of sort of what are those consistent messages, and it's something in Leeds we've done quite a lot of work on, and we describe as the 3 C's of communication, coordination and compassion. They are the 3 things that form the basis of complaints, feedback, insight from all of us across our health and care systems. And when done, is very positive and has positive impacts on our outcomes, but they form the basis of many of the complaints. What do we mean by communication? Well, just some questions to pose here. Do we talk in a non-jargon way so that we can all understand what's being said to us? The average reading age of people living in the UK is 9 years old. Are we writing our websites and our materials so that everybody can understand those materials? Do we enable people to have the time and feel willing to ask questions? If people are diagnosed with conditions, do we give them appropriate time to be able to ask questions, especially if people have additional communication needs, such as hearing loss, English as a second language? Do we know and understand how people can receive information? There's an accessible information standard, which should be all health and care organisations should be adhering to, but often that is not adhered to. So, we know of people with hearing loss receiving phone calls for appointments, people with sight loss receiving letters for appointments. How do we get that right? And do we give people the information when they need it, particularly when waiting for treatment? So communication is absolutely core to health and care services, but it's often one of those areas that perhaps we don't focus on as much. Understanding the population that we're serving, the people that are accessing health and care, we are often, I myself have got hearing loss at the moment, but it's people who may have communication needs, may have English as a second language, may have disabilities, may have learning disabilities. Those are the people that we should be making sure that our health and care services are designed for. The second one is around coordination. We sometimes make services really complicated to access with multiple referral points, different organisations to try and contact in terms of accessing care. As I say, different ways of trying to access care, and often the services behind are not talking to each other. So people have to join the dots in terms of trying to make sense of the care that they're receiving, and particularly unpaid carers. Unpaid carers, we've heard a lot around unpaid carers experience. Many unpaid carers having to give up work because of the complexity of health and care services and having to navigate that. and I should have said I did have a stat actually around the communication element. Carers Leeds have just done their annual report on caring, and 41% of respondents said communication with carers from health and care services was poor or very poor. And the third one around that is compassion, the vital role of compassion in delivering health and care services, and whether that's receiving end-of-life care, whether that's receiving mental health crisis support, whether that's receiving maternity services, compassion is core to the services that we receive. So we describe those as the three C's. The next one on the list, sorry, I've just lost my list for a minute there, is around getting access right. We made enormous changes to accessing care with COVID, seismic changes to the way that people can access care, particularly with a digital focus, and a real call in all our reports around getting that right, around taking a nuanced approach to the delivery of health and care in a digital way, and repeated ask that there is always an alternative to being able to access care in a digital way. The next message was around understanding who is accessing services and recognising the impact of poor access. That can have elements in terms of trust with communities, and a call to, are we measuring actually who is accessing our care from an inequalities perspective, and also who isn't accessing our care. And then I'll just, and then another message was around, in all those reports, was around the positive outcomes of delivering care in a different way, in communities, working with communities, particularly third sector, and the role of third sector community organisations. There are people described being able to access care in a way that made sense to them, done in a different way, particularly delivered in community. And then how do we mainstream that good practice? And then I'll just close for the main points around how do we ensure that prevention and wellbeing is part of who we are as a West Yorkshire health and care system going forward, so that every community neighbourhood has access to good prevention and wellbeing. So those are the key elements. I would say then they haven't just come up in Health Watch reports, they come up in all the insight work. And if we reflect on some of those key West Yorkshire pieces of work that we've talked about at the board and made commitments to, such as the Equality and Diversity Strategy, there's many of the repeated themes within that. The Dame Donna Kinnair work, again, many repeated themes. So, there, and also some of it, or much of this, is backed up by legal duties, such as the Public Sector Equality Duty and the Accessible Information Standard. So people have told us consistently about how we deliver care in a person-centred way that meets the needs of all our different communities in Leeds. There is statutory duties to do that as well, that encourage us to do that. So I suppose the challenge and the questions I have for us as a health and care system, particularly as we go into this new phase of massive or significant change for health and care planning, is how do we put them at the centre of neighbourhood health? Can we create neighbourhood health services where we have plain English, where services are easy to access, where we have a representative workforce, where we design with communities, where we measure who isn't coming to our services? How do we measure these core components as part of our quality systems going forward? We don't know what the role of the ICB will be around the delivery of, or the assurance around quality, but wherever that lands, we've got to make sure that these components are part of that. How do we and how do we ensure these elements are core to the new what's been described as provider partnership? So the ICB roles is going to change. There are going to be new arrangements or new ways that services will work together in local places. How do we make these wisdoms from communities at the core of those works? That work. What we don't want to have to do is start afresh with those new arrangements. We have I would say, people have kindly shared their experiences over and over again, and much of the messaging from them is, can you act on what we're telling you, please? And I suppose that's the plea from this piece of work. Can we act, and can we take those forward into the new arrangements? And from a Health Watch perspective and all the other voice partners, we're very happy and willing to work with you to develop that.
Thank you very much indeed, Hannah, for those observations and the work that you've done there. The core themes around communication, access, equity, prevention, well-being and being person-centred are really at the heart of what we do in West Yorkshire, and we do want to keep that at the centre of everything we do as we go forward into our newer landscape. I just wondered if, before we step into next step, if people had any comments, views. Fatima, you've got your hand up.
Thank you, Chair. Thanks, Hannah. Really comprehensive overview. And I think, as you said, there's a lot of correlation and translation to the equity and fairness strategy, and a lot of the themes that you identified were similar to the engagement that we did at the back end of last year. Just a shout out to everybody who's watching. If you do want to check out our equity and fairness strategy, you can find it on our website. I suppose a couple of reflections for me. The first one is, how do we translate this into action? So if we are finding the same things repeatedly, then something is clearly not working, and then we need to repivot and think differently in how we make that happen, particularly in light of the new ways of working. If the new ICB blueprint, the word of strategic commissioning, accountable care organisations, etc., how do we make personalisation and supporting people on the periphery of society something that is embedded in the DNA of how they operate? And I think there's a role for us in the future, but it'd be helpful to understand other people's perspectives in that. I suppose one of the things I was reflecting on when I was reading it was specificity. So one of the things that we did in the equity and fairness strategy was highlight specific groups that the data were telling us that we need to prioritise to ensure that we move on that remedial action at pace. It'd be really helpful to understand whether Health Watch identified any of those to help us. And then I suppose the other bit as well is influencing upwards as well as influencing regionally. So I had the privilege, it was a privilege for me, I'm not sure if it was a privilege for the Secretary of State, to attend a roundtable to discuss integrated neighbourhoods, and it was a real privilege to share some of the work that we've been doing on integrated neighbourhoods. Thank you to our Deputy Chief Exec Ian Holmes for sharing some documentation that I passed on to the Minister. One of the things we did discuss was the importance of personalisation, about joined up care and about communications, but also a real concern about how we involve everybody in that caring conversation. So again, unpaid carers were a massive part of that, and I was late to the board this meeting because I've just attended the keynote for the NHS Commitment to Carers conference as well. So we are, as an organisation, trying to influence the national narrative too. I suppose my second follow-up question is we've prioritised unpaid carers as a key cohort for our Healthier Working Lives programme. That's the shared working that we're doing with the combined authority. And I suppose there's something about an ask for Health Watch to support us with understanding that we're getting it in the right direction, that we're achieving what we should be, but also being able to repivot as and when we need to. So there's an ask there really for some support. And I suppose my sort of final question is there a way in which to embed in the new sort of governance ways of working? You mentioned sort of the quality standards, and I really think equity and quality go in hand, but are there more ways in, say, transformation, strategy, or some of the new elements where we can really embed elements of experience and access as part of the DNA of what we're meant to be doing? Because we need to do something differently, and I'm not quite sure we're getting the assurance that we're doing all the things we should be. Thanks, Chair.
Okay, did you get those questions then, Hannah?
Sorry, my poor hearing. I didn't get the one about data. That was the only one.
So it's about specificity of significant cohort groups that are experiencing a lack of equity regarding access, experience and outcomes that we could focus on as a group, just so that we're reaching the people that need it the most.
Any
Sorry, I was waiting for more questions there. Sorry, I was poised. Yeah, I suppose on unpaid carers, yeah, we would totally echo that, and we've done some work, again at a West Yorkshire level, reflecting, I think, on some of the board papers that come to the West Yorkshire ICB, and thinking, what are those real risks to the people of West Yorkshire? And one of the risks we've identified is that risk to unpaid carers, that if we're not careful in the design of future health and care services, the talk about self-management, the talk about in the community, if we're not careful, there'll be even additional asks to the role of unpaid carers. And so that conversation, and it feels like it should be almost a contract's the wrong word, but working together to understand what do unpaid carers need to enable their role. Not having to call the GP at 8 a.m. Being able to pick up the phone if the person that they're supporting is having a flare or is unwell. There are certain things that unpaid carers need to do their role really effectively, and I think it's it would be good to move into that position of, rather than just sort of pushing more onto unpaid carers, but to be having a conversation around actually what works for unpaid carers. So that interestingly, in the Leeds annual report of caring, again, the impact of caring on the carers' own health and well-being is significant. And you'll know all this, Fatima. But how do we move into that space around really working with carers? Interesting, our carers, or representative organisations sitting around all those tables in terms of being able to be part of this new health and care system. And from a Health Watch perspective, I can't really speak on behalf of all the other local Health Watch, but at a West Yorkshire level, definitely, and from a Health Watch Leeds perspective, we would definitely support any work around that. In terms of data on specific groups, yeah, we will have lots of that intelligence. So yes, very happy to share that. And then in terms of those other challenges that you put out, I think they're more challenges for the group rather than me. I think that sort of builds on the group, on the challenges I was putting to the group, really.
Okay, thank you, Hannah. We will get to the challenges. We have Majid first and then Rob.
Yeah, thank you very much for that report and presenting the sort of key themes from it. As I was listening to you and sort of read the report earlier on, I've got the model ICB blueprint in front of me, and I'm thinking to myself, well, what a huge opportunity to address those points, point by point. Point one on there, into understanding local impact, how understanding local context, understanding local needs, hearing from underserved communities. Also that first part about listening and stuff. Then the next bit around co-production, next bit around how do we build into contracts what we learn from communities, and then getting communities involved in evaluating impact. So the answers to many of the issues that have been highlighted from the report presents us with a huge opportunity to sort of build them into the system. Similarly, around neighbourhood health, again a huge opportunity in terms of access and care close to people's homes, etc. So I think one of the things that we could do is building on the scenario work that was done, where we picked 4 scenarios and how would a future sort of ICB address those issues. We could actually pick this report up and say, in our new model, how and where are these issues picked up and addressed. So I think that's something that we could definitely do. The other thing is around cultures and behaviour. So in developing local workforce strategies, how is this report then fed into the work we're doing around values, culture, behaviours, etc., and then building that into leadership appraisals, etc. So I think there's a joining up, not just in relation to a future model, but in terms of our future sort of culture, values, behaviours, etc. So I'm seeing a huge opportunity and a timely sort of summary report here. Thank you.
Okay, thanks, Majid. Rob?
I'll come in a bit.
Okay. Ian and then Jane.
Yeah, thanks, Nedra. Thanks, Hannah, for the report. Couple of quick points. I think the first one is exactly right in terms of what do we do with this next as an ICB, and it seems to me that there's some of these actions we've got quite a lot of work happening on currently, some much less so. Some will be really important for us as a strategic commissioner, and some we'll want to work with partners on, really. So I think a little bit of a kind of a mapping just to say where do we think we are against these and how do we fit them against the blueprint work that we're doing would be really helpful, as Majid's described. The second thing, I think there is some really specific learning for the work that we're doing around integrated neighbourhood health, and with Mel and Sue's sort of support, it'd be really good to take this into the board, the Integrated Neighbourhood Health Board, maybe invite you along so we can ensure that the learning is being cascaded through that route as well.
Yeah, thanks. I think it's building a bit on comments already, but I guess keen to see, because there's a real richness of information here and insight, and I'm just wondering, beyond us as a board and our sort of structures, etc., how do we make sure that all of our providers see this and just, it's put in front of them? I'm sure it's on a website and people can access it, but maybe being more proactive in just making sure people are consistently hearing this and having their own sort of local responses to it, I think, and just encouraging that rather than just rely on us and some of our committees doing that, I think would be really helpful.
That's great. We'll have Debs and then Tim.
Yeah, thank you. It's really, really useful report, and I was really interested in what good looks like. So we've obviously looked at what the challenges are and what some of the problems are. I think it's really helpful to understand. I'm just looking at the slide with coordination on, for example, what our communities and residents and patients telling us good coordination looks like. And I think that'd be really useful. So I don't know if you've got anything, Hannah, that you share with us. I think sometimes as services we jump into solutions like, there must be a million connectors and navigators and coordinators that we've decided are the answer to this, but actually probably the answer is making our services more accessible and easy to use. But it'd be just really helpful to understand what communities would like to see, and perhaps with some of the engagement just have a appreciative, positive questioning that tells us what good looks like.
Thanks, Deb. Tim?
Yeah, thank you, Hannah. I thought it might be just useful because, as Hannah said, particularly the 3Cs framework, we've been using in Leeds for a while, thanks to the work of Healthwatch and the People's Voices group that Hannah's been coordinating in Leeds and leading. And we've wrestled with this. Do you set up a big training programme? Probably not. How do you build this in? And a couple of sort of observations. Organisations have taken this on. And our partnership leadership team have received, a presentation back from organisations about how they've done that, and some of it is really innovative and useful. So that framework is quite a powerful framework when you start to think about quality. We're nowhere near where we want to be, but we've started that journey. The other thing is building it into your major change programmes. So Ian referenced neighbourhoods as a good example, but right across all our major change programmes, we are trying to build that in. And I deliberately use the word trying because it's a bit of a change of culture, and Hannah rightly challenges us sometimes. But it seems to me that in real change, if we're not able to create a compassionate service, if we're not able to coordinate and for people to feel it's coordinated, taking your point, Deborah, it shouldn't really be necessarily about people coordinating, it should be about a simpler service. And if the communication's poor, we probably haven't really done good transformation then, have we? So I think there's something about building it into real change as some of those principles. So that's where we are. We're still on a learning journey, but we have had some experience because those 3Cs have been around for a couple of years now in Leeds.
Thanks, Tim. We have Shaukat and then Therese.
Thank you, Hannah. I think it was very, very interesting. Just one part which I just wanted to bring your attention. We have recently started the digital and AI literacy program, and that is not only for staff, but also we will be offering for the communities. And one of the areas is for them to connect how they can ensure their access, and then what are the available tools so that they can connect to the respective platforms. So I think that may bring some more support into the community's part, especially with regards to access and with regards to how they can ensure their person-centric, holistic care. Thank you.
Yeah, so building on Tim's point, just to give you assurance that we certainly have taken this on board in Bradford and Craven. We're proud of the listening work that we've been doing in our place for the last couple of years. We started in the first year going to different places across our district, and then in the latter year we've done cohorts of people, so children, young people, or older people, or people with disability. And we've really done what they've said, listened to what they're saying, and a lot of the things that you were saying, Hannah, in your report about access, about communication. What we have done more recently in our place is developed our healthcare and wellbeing strategy, and this is actually the fundamental piece. There's a bit around the what, which is the population health bit. How do we start to improve the health of our population? But then there's a bit around the how. How are we compassionate? How do we listen to our people? How do we take services out to the communities where they want them? So as Tim says, it's a work in progress, but I do think it's actually front and centre in terms of the work we're doing in our place.
Just a couple of questions. Tim sort of answered the question around providers. Yeah, we totally don't see this as just a West Yorkshire ICB role. And as Tim mentioned, LTHT have done some really exciting work around the 3Cs. They're now measuring every business unit in LTHT against the 3Cs. Is care well communicated? Is it coordinated? And is it compassionate? Which feels really exciting. So yeah,
there is exciting work to do, and it's great to hear the work at Therese around what good looks like. Definitely, we've got good examples of that, and we've in these we've done a piece of work together with the People's Voices Partnership, so not just Health Watch as health and care voice organisations, following people in their health and care journey, and we always ask, and what was positive about your experience, and there are so many examples. I mean, we watched one of those videos here at the board. We followed Abdul's experience, and he talked about how services were particularly culturally aware in terms of what his needs when he was in hospital. So yeah, we've got those examples, but we could. It's a good reminder to maybe do some of that work around what good does look like, and then just on the digital. I think I think with digital it's the nuance of really understanding who are the people that we're trying to serve. Some people will never get to the digital solution, and that's a really recurrent theme, that there will always have to be a non-digital option for people. But the more people that we can support to have those opportunities, if possible, would be great.
Thank you, Hannah. Fatima, and then Rob.
So just coming back on this really insightful discussion of all the transformation that's taking place and all the good practice that's going on, one thing that I'm clearly hearing from Hannah's report is, despite that, the public are not seeing it and they're not hearing it. So is there a way in which we can amplify that to address the public's concerns and to show them that change is happening but maybe need to be tweaked to reflect the experiences of people? And then my second bit is, if there's loads of activity going, how do we know it's the right activity, and how do we know it's getting us where we need to go? So, Ian mentioned the Integrated Neighbourhood Blueprint, Majid mentioned the ICB opportunities. How do we know we're getting there, and how do we close that loop back to the public that we're addressing their needs, I suppose, is a bit that I think we could be stronger at, just reflecting on what we've just heard.
Yeah, thank you very much for that, Fatima, because I think in our discussions we've come up with a number of ideas forward. Hannah?
Just on the feeding back to people, that's absolutely one of the themes that people have said. I think they said it in the engagement around the equity strategy as well. We keep saying things, but what's actually happening? I know within Leeds we have a principle from Voice Partners around the importance of feeding back to people and showing progress around that. And I know West Yorkshire Voice, again, have been working with West Yorkshire Partners around, there's such a lot of work going on around improving GP access. How do we communicate that to people? So yeah, you're right, Fatima, it's an ongoing piece of work. Sometimes we sort of do the work, or some of the work happens, we just forget to communicate that back out.
But I also think there's a role for us all as individual organisations and a collective to be articulating that too. I think that it's a joined up thing that I'm keen we get.
Thank you both. Rob?
Yeah, so really good conversation and helpful reminder of the work. I think just worth reminding people around the table, because not everyone's been involved, and for people who are watching the live stream, that this is about 4 different sessions we had as a board. It's not about Health Watch taking work on. It's about 4 sessions we had as a board over a year, across that year, to look at some specific issues, bringing in the public, partners, professionals, board members, to debate what we could do, what the issues were, what we could do about them. And I think the Health Watch report's really fantastic input into those. They're not the entirety of the work. I think that's quite clear from the conversation we've just had. And I think the big test for us is, have we acted on what we discussed, and is it making a difference? And as others have said, is it become part of the mainstream work that we do? And I think we could look at, for example, maternity and the work we've done there. So we've got one of our 10 big ambitions is to reduce maternal mortality and stillbirths and disproportionately improve the position for people from different ethnic communities. And we're making some substantial progress on stillbirths, but not on maternal mortality. And part of the reason why we're making some progress and actually making faster progress for those different ethnic groups is because of the work we're doing to address inequalities and because of the focus we have on it. I think the Maternities Voices Partnership, good practice we've got in some places, and where we're attempting to strengthen that, to get that voice much further into the way we make decisions and design services is an example. the way we've segmented some of the information into our local maternity and neonatal system is part of that. And I think a lot of that is driven by the conversations we've had in those sessions. Now, if we were to look at the blueprints later on integrated neighbourhood teams and urgent emergency care, I think we should take a critical eye to say that, you know, is the way that we've designed this mainstreaming it so that we implement things in a way which people are going to notice, and the difference is going to be made in the way that Tim's described in Leeds or Teresa's talked about in Bradford, and I'm sure that partners from Caldale, Wakefield and Kirklees could give a similar story. But we probably need a better way of systematically saying, you know, we've done all of this, this work, and of tracking the views of the public changing over time. But that simplification of all of that into those themes is really helpful, I think, Chair, and we should keep coming back to it. So there's probably a test today in the later items just to give it that critical eye. And then I think there is a test for tomorrow, as Majid said. This is strategic commissioning, isn't it, to sort some of this stuff out. And then there's a test around, can we start communicating this better? Now, what I would say is we published our annual report last week, didn't we? We agreed our annual report on accounts, and that's chock full of really great examples of stuff that we've done, the improvements that we've made, and including in health inequalities areas. So no one's going to read that in the detail that we've read it because it's so huge. Finding ways to communicate that more effectively, we can take away as an action, I think, and Ian might want to do that with Paul and the team. But I think it's a really good conversation and one we should really still keep being challenging ourselves around.
Yeah, absolutely. I reiterate that. I think also there's something around the impact of what we've done and what we've heard and what we do with it. And I think if we keep that lens through the meeting today and ask ourselves those questions around how does this fit into what we've heard from our focus on groups, and also there's something around measuring that impact. How do we know we've done well? There's also something around, well, we'll never achieve our ambition completely because there's always be something or some areas we need to continue working on. And I think one of the reasons why I think we've done relatively okay so far through what's come out through your report, Hannah, is that it's all been done in partnership. And partnership is very much the way we work at the ICB, just looking around the table here. And I think that's something we need to celebrate and also to let people know that it's partnership that delivers good health. It's not just one particular part of the NHS. So I think there's another area for us to think around, and that's sort of next steps. What do we do with this? And I just wondered, Rob, what your thinking was around, do we have more focus on groups, or do we take it away and then think about it, or we try and consolidate what we've already done? And I'm really conscious of the work that Shaukat Ali Khan is doing around digital literacy in the for and with the wider community. And I think that feels so groundbreaking, and it's something that we need to emphasize and keep going and make sure people can access that.
I think it's a good suggestion in terms of how we take this approach and how we deploy it in the future. I think we've got a board development session coming up in a couple of weeks, and we might want to ask that question in the context of two things, some of which are highlighted in my report later. Firstly, the 10-year plan for the NHS, which is due to be published in the next few weeks. And secondly, in our new role as a strategic commissioner, rather than an integrated care board supporting an integrated care system.
Okay, thank you. Once again, thank you again to you, Hannah. We've noted the key themes, and we're definitely going to be taking those forward and working on them. So thank you. Thank you all for your discussion this afternoon as well. So our next item is the Board Assurance Framework. Laura Ellis, over to you.
Thank you. Yes, I'll just do a brief introduction and then and see whether there's any questions or points for discussion. So the Board Assurance Framework, the BAF, is shared with you. This reflects the latest quarterly review of all of the risks. There's been a very real focus this quarter on how the risks are impacted by organisational change, and we spoke about that briefly at the last board meeting. That was one of the challenges to risk owners, to go away and have a bit of a think about how we needed to amend those risks and also think about our assurances. I do think there's an area for consideration for the board about whether we want to include a new principal risk on the board assurance framework around organisational change, as well as making sure that it's embedded within the other risks on there. We do deliberately schedule the board assurance framework item quite early on our agenda, and that is so it can be used as a reference point as we work through the rest of the items. We particularly draw the board's attention to risk appetite. It's important that we keep that in mind as we work through the other items on the agenda. We are expecting but we've mentioned already a couple of times that we're going to be having a board development session in early July. We are intending to focus on risk appetite in light of organisational change, and that'll be one of the areas that we focus on during that day. I think just the final thing to flag is that you will, in relation to that last point, have seen it through, I think, the committee AAA reports as well. So this is where we try and make sure that we're triangulating the discussions that are happening in the committees, coming back up to the board, and you'll have seen in there that a number of committees recommended that we did need to spend some time thinking about risk appetite in light of change. I think those are the main introductory points. Thank you, Chair. I'll pause and see if there's any questions.
Jane?
Yeah, thank you, Chair, and thanks, Laura. So initially I was really interested to see how the risks scoring has changed, and I was particularly looking at item risk 2.1. So this is about our ability to collectively recruit and retain staff across the sector, and obviously we're very keen to protect our frontline staff and be able to recruit into that space, though there's obviously a lot of change, as it references in the paper, within the NHS system that probably puts added pressure into that. It references the anticipated long-term workforce plan and social care workforce strategy coming imminently, we hope. And I was just wondering, to what extent have we got a sense as to whether that is going to be tangibly helpful in this space? Because, we were under pressure anyway in terms of workforce. The changing environment adds a new lens of complexity to that, and it's really important that clearly that we get something that is going to help us in that space. I was wondering if there was any insight on that. Whilst on the other point, Laura, that you just mentioned about the organisational change and how that impacts into here, obviously, I guess I would expect, with my risk hat on from audit committee, it's very immediate in terms of risk register will definitely, I'm sure, have lots of stuff. And I guess I'm kind of thinking, actually, by the time we get the new model ICB and we transition to that, as well as looking at risk appetite, we will probably need to reframe anyway what potentially the BAF and the strategic risk areas under our new clarity of responsibilities, etc. So I wonder whether we focus on risk register for the organisational change piece, be mindful of it in this and the risk appetite review, but then anticipate doing a wholesale kind of what does the BAF look like once we're moved to the new model.
Thanks. Sounds very sensible. Any comments, Rob?
I think it's definitely the case that the risk register and the programme risk register on the org change contains a lot of risk, as I've stated in my report, and we're clear about that. I do think there's a way in which we could recognise that the organisational change, not just for us but for our providers, for NHS England, for the department, for councils, will continue for more than a short period. So I think we're looking at 18 months for the legislation to change. So there are things we will be legislatively accountable for. There'll be things that nationally aren't going to be in place for a period. So I think, we're really looking at April 27, aren't we, to be on the other side of some of the changes in the system. So I wondered if we tweaked 3.3 and 4.1 slightly, we could cover that, because we could talk about capacity and infrastructure not being targeted appropriately in the context of the change, in 4.1, you know, partnership working on wider issues deprioritised in order to meet operational and change, structural change issues. There might be that kind of thing. So we could probably make some minor amendments. I'm just anxious, Jane, about the length of time it's all going to take. Makes it more of a strategic risk.
Thank you, Rob.
And on the workforce, Kate.
Oh, yes, please, Kate.
Thanks, Jane. Yes, I mean, as you can see from Laura's paper, the risk has been increased on this very point that you've raised. We are advised, obviously, as part of the NHS 10-year plan, that there is obviously the section around workforce. And I understand that from that, the long-term workforce plan, I think there's work to review and consider what that means from that perspective. The adult social care workforce strategy, you will all recall, was launched last year, and that there are still, there's numerous parts of the work in terms of implementation of aspects of that. But I think you're right. I think that, we've always said there is this risk about our ability to recruit and retain. More locally to home, we have a really, sort of well-established now strategic workforce forum, which all of our partners, including our education partners, because we recognise that some of the priorities around growth and retention of the workforce we have to respond to together. So there's some quite active work around linked to things like the neighbourhood sort of health model, also linked to some of the apprenticeship work that's happening in West Yorkshire. So I think this is absolutely one to watch. I haven't got any firm indication of when that long-term workforce plan position might be revisited, other than let's see what it says in the 10-year plan when it comes out. And I think all of that reflects why this risk has been increased. Thank you.
Okay, any further questions or comments? Yes, Rachel.
I was just going to add to Kate's bit about the risk to the social care workforce. Is obviously we've got changes in international recruitment that are now going to affect social care and home care workers as well. So that needs to be added into the risk register. Yeah.
Thank you, Rachel. Any further comments? No. So we've reviewed and updated, added to the board assurance framework. And also one of the things we like to do is to ensure that the framework is referenced to and is used throughout our discussions today, with a particular focus on the risk appetite to inform any decisions that we make. Thank you. Right, which moves me on to the Chair's report. This is my first report as the Chair. I took up the role of Acting Chair on the 1st of June. Following Cathy Elliott leaving to go to Merseyside. I hope I can do justice to the work that she's started, and with her support through all of this. So this report is basically about her work with 1 month of my work in here, okay? But I'm really, really pleased to be here, and it's a job I can only do with your support, so thank you for that. I'll just highlight a few things here. We've tried to make sure that the paper and the areas of note within it are around compliance and national requirements and good governance and equity and fairness. So one of the key areas has been working on the 10-year plan, and in the light of Hannah's report, I can say that we've done quite a number of roundtable consultations with community organisations, and I think some of our figures go into the thousands of interactions, etc. So really pleased about that. Another issue has been looking at reducing the running costs by 50%, and I think papers and discussion around that will come up again later on today. Both Rob and I have had meetings with the regional director as well as others within our system nationally, and are quite challenged at the moment in terms of how we're going to achieve this in terms of fairness and equity, and also keeping the values of our system, the way we work in West Yorkshire, at the foremost front of everything that we do. We had our annual governance review. We've had a board development day. The board development day in April was obviously very much focused around the future of the ICB and our partnership working. We've also done some work around board succession planning. For example, 3 of our non-exec members have had their contracts extended for a year, and some of our partners have also had some extensions to date. I think those are my highlights. Just wondered if anyone had any questions or comments around the full report. Fatma.
It's not a question, it's more of a reflection and a sort of acknowledgement of gratitude to the comms team in particular, who have done some really proactive and innovative work in trying to influence the 10-year plan. So it's just a sort of acknowledgement for that. And then the other part is to really acknowledge some of the work that's gone into the work and health plan. And this is an example of this is what we do well in West Yorkshire, working across complex footprints, across organisations to do things that matter to people, which is getting them into work. And then the report really highlights sort of a high-level overview of some of the work, but we can't underestimate just how hard people are working on what is quite a time-critical piece of work, and I hope that this is something that will continue in the future.
Okay, thank you, Fatma. Paul Hemingway, our Assistant Director of Corporate Communications. Hope you'll take that back to our teams there. And I think I didn't say here, but we've set up a transition team, a committee to actually look at how we achieve some of the requests and requirements of NHS England going forward, but also keeping in mind the well-being of our staff and making sure that our services run as smoothly as possible until those changes occur. So thank you, everybody who's been involved.
Yeah, thank you, Chair. So as ever, I'll take the report as read. There's a substantial amount of material in there. I'll emphasise a couple of points and give you a bit of an update on a couple of new things, one of which I'll bring Bev and James in to give some more intel on. So just to, I think, start at the end of the report, which is this is a period of substantial and significant change in the short term and into the medium term. We're working incredibly hard and making substantial progress on changing our structures in a context where we have to deliver an incredibly challenging operational and financial plan with our providers and partners, and where we're about to see the 10-year plan for the NHS be introduced. So we need good collective leadership that brings confidence and consistency and clarity where we can find it for all of our staff and for the public. And I think we're pretty good at that, generally. I think we're pretty good at, focusing on what really matters, which is improving outcomes for local people. So hopefully you can see that reflected in the report. In this period, some things have become much clearer. So the spending review for the Department of Health and Social Care has been relatively positive, 2.8% real terms growth, with 3% for the NHS, which means non-NHS parts of the DHSC will get less than the 2.8%. Flat real growth in capital, which is code for flat investment in capital over the next 3 years. And issues like how we plan for the winter, where we will be required to do that, backed by a national urgent emergency care plan to the fall. In that context, I say we've hit all the deadlines that have been asked for us in terms of updates to the plan, our 45% reduction and the plans for that. We continue to work with the region and national teams to try and make sure the other moving parts are in play. So we need a model region to work with to deliver the workforce, digital provider oversight functions that they'll have in the future. We need the national organisation to deliver the data that it promises to allow us to be a strategic commissioner. And we need our provider colleagues to work in partnership to pick up the place work and deliver integrated care. So we're managing all of that, and I think we're doing it pretty well as we can in this current context. Since I wrote the report, there's been 2 or 3 developments which would be worth highlighting. Yesterday we received some frequently asked questions and some further detail about the chair and chief exec selection process. And the frequently asked questions were helpful in terms of confirming that our approach to what's in the £19 per head is the right one. Just to remind board members, what we've done is put everything we expect to pay for from Q3 into the £19 per head, irrespective of whether we will be doing it in the future or not. So that's been our approach. So continuing healthcare, medicines optimisation, work around the integrator functions for providers to collaborate successfully is in our £19. I think the national moderation work had suggested there'd been a bit of inconsistency across the country. So I think that hopefully means there'll be less change for us in what's in and what's out, which I think is reassuring. The other thing that came out yesterday was a letter about a national investigation and piece of work around maternity services, and there's a bit more clarity on what that might mean in the letter from the Chief Exec of NHS England and the Chief Nurse. So James, I don't know if you just want to give a couple of brief highlights on that.
Yeah, no, thank you, Rob. So the Secretary of State announced yesterday that would be a rapid independent investigation into our maternity and neonatal services across England there. That would be an independent task force that will look to kind of understand and act on systemic issues behind those experience unacceptable care across the system there. This will start as soon as possible and will look to kind of finish in December. And as I said, it will be an independent investigation there. It will look at culture, ensuring that we have the right culture, understanding where poor culture takes place, but also highlight the right culture as well. More importantly, it will also listen to families to understand their experiences as well there. It's about something about kind of reviewing our data on quality of maternity and neonatal services and making sure we have that awareness and are able to kind of see that as well there. And particularly kind of a focus on inequalities and tackling health inequalities, discrimination and racism there. So that's kind of a quick summary of the announcement yesterday and the subsequent kind of letter that was sent to us following that announcement. I don't know, Bev, is there anything else you want to add?
So just to confirm, we've had no communication to tell us that any of our organisations are included in the process to date, and we'll wait and see whether there is any confirmation of that shortly.
Is there a time scale?
So the announcement yesterday said that by December of this year that they want to conclude that, but they will act throughout.
I think it's worth just adding on that. We discussed this a little bit, didn't we, in the last item around, a couple of items ago around the work we've done on maternity, and we've had significant conversations here about maternity services from a performance and a quality perspective, and we have a well-functioning local maternity and neonatal system that Bev chairs and involves all of our providers. And we have some really good practice in West Yorkshire, but we also have some very publicly voiced concerns about some of the services and stories from some of our families that we need to address. And one of the things that the letter talks to very strongly, I think I'm very welcome to see elements in the letter around the culture, inequalities, and any issues around structural inequity due to race. I think that the letter talking to provider boards and boards like ours paying due attention to those issues and performance and quality is very helpful. I think we would anticipate and are aware that there'd be a very strong response from our providers and from our local maternity neonatal system in terms of how much time and effort goes into these issues. We need to retain a curiosity professionally and a degree of challenge which allows us always to get to the right place on those issues. So I think we'll pick up anything that comes out of the national inquiry, but I think we'll also want to make sure that we are working incredibly hard to make sure services are providing high quality, effective and safe services.
Okay, thank you for that, Rob. Questions? Fatima?
It was not a question, Chair. It was just to add to Rob's points about the fact that when we did the evaluation into the impact of inequalities on our wider communities and staff from ethnically diverse backgrounds, we incorporated into that maternity services as an area of future focus. We are also working with our VCSE Voices panel who have connections into diverse communities to try and support the community of good practice that already exists to ensure that we address and support our communities with any concerns that they've got, and that meeting is taking place this Wednesday. So there's an offer of support there for colleagues should they wish to use it.
Okay, thank you for that offer, and also it'll be really helpful to hear the feedback that they have around our services. I'll take Jane and then Hannah and then Majid.
Thank you. So yes, so on this maternity, the point and the inquiry, I guess I'd be just interested, which is obviously really concerning for those who've been affected. I'd be keen that we, as a board, kind of think about how we are kept up to date and have sight of kind of what comes from that and what work goes on within our patch, obviously. So if we can reflect on that as it becomes clear in terms of how that process will play out, that would be really helpful. There was another point I was just going to mention or ask about in your report, Rob, about specialised commissioning. There's a section that kind of updates about how, because that has been a live discussion at the board ahead of the decision and the agreement that we take on that commissioning responsibility from 1st of April. Though obviously it's still the current change in the system is impacting that. I don't know whether there's any further updates since when the report is written or insights as to what we think might happen in that space. That'd be helpful. Thank you.
There's nothing in addition to what's in the report, as far as I'm aware, unless Ian has picked anything up from his work as the lead on this with Phil Wood from LTHT.
Okay, Hannah.
Yeah, just a couple of points. Just on the maternity, I suppose just to highlight the last report that we did, the ICB Focus On session was around the experience of people at risk of experiencing inequalities and their maternity experience. So there was a lot of insight within that, and it wasn't just Healthwatch insight, it was insight across all our, across West Yorkshire and wider. So, and we know that's being used locally, but it is a really good source of information around people's experiences with a series of recommendations. On the the significant changes that are happening around NHS planning, I suppose. From a West Yorkshire Integrated Care Board, there's been such a strong commitment to the involvement of people and communities in terms of decision making, and that's testament to the leadership and the way of working at a West Yorkshire ICB level. I suppose it's just about ensuring that is built into new structures. So what will that look like in the next version of the Integrated Care Board? What will that look for regional teams? I know we have limited influence around that, but it would be good to, and I'm sure we're playing those messages in, but the importance around people's voices, particularly of those experiencing inequalities. What will that happen in the new sort of provider partnerships as well? What will that look like, and what will that look like in neighbourhoods? So it feels like there's a really important piece of work potentially for us as a ICB to be assured around that level of involvement and embedding of people in decision making as much as we can do. And then my last point is around just again a thanks to ICB colleagues and the way colleagues are managing this significant change. This is highly significant and done at such a pace, and the work to minimise the impact as much as possible, is sort of the team have done an incredible job around that. I suppose the challenge for us in the public is trying to understand what will this mean to services, what will this mean to any changes in services, and being able to articulate that would be really good as soon as we can. We know that when things change, when systems are changed, it can have an impact on quality of care. That's the reports that find that every time. So how are we minimising that? And again, how do we communicate around what will this mean for people?
Okay, I think that goes back to your question or your observations from the focus on groups. I just wondered, Rob, did you want to say anything around that?
Yeah, just on the engagement piece, I think you can't be a strategic commissioner if you don't understand what people are telling you, and I don't think you can be a good, effective provider as well if you don't understand what people are telling you. And I think we've built some capacity in around engagement and co-production at a strategic level, but we've also built that into the integrator teams, the teams that are going to join up services and do more with our providers. I don't know, Tim, if you wanted to reflect a bit on the sort of insight and engagement role of the integrator function, because you've done a lot of thinking about that.
Yeah, certainly. So in terms of the integrator function, I think there's probably two places this connection back with people is built in. One is we've recognised that we need to ensure that through all the different mechanisms that often exist in places, that is coordinated and brought together to enable localised planning in an effective way. So there's definitely that kind of capacity put in there. And then secondly, in the way that we've talked about design and change across the integrated function, in a number, I've been doing job descriptions quite a lot recently, and in a number of places we were really very keen to be quite clear that co-production is a fundamental part of that individual or those teams' jobs. So in that sense, we're building it in not just into the understanding what people are saying to us and how that shapes services, but then actually into the design and redesign with provider partners and other colleagues across cities, that those people are part of the design process.
And in terms of, what we don't really want the public to notice the structural changes. We want them to notice that services are getting better. I mean, nobody could fail to be moved by the experiences of families in Leeds that have been on the BBC and elsewhere in the last week, because their experiences will be felt lifelong for those families. And, I know we would all pass our condolences and thoughts to them and feel apologetic and sorry for what's happened to them, because it needs to be better. And I think that should be the test that we're applying to all of the changes. Do they deliver the things that we've said we wanted to do, about reducing suicides, about reducing maternal mortality, for that being significantly faster in areas where we've got significant inequity, whether that's due to race, mental illness, learning disability or poverty. So those are the things I think we need to focus on, and the technocratic elements of it are of interest to us, but they shouldn't be necessarily of interest to the public.
Yeah, I think our services have to remain seamless to our people who are receiving them. Thank you for that, Rob. Majid, and then Beth.
Yeah, thank you. Just a couple of quick things. So just docking back into the earlier report from Health Watch and linking it back to the piece around maternity services, and a lot is said about values, behaviours, compassion, kindness, etc. And I'm just thinking, have we got an opportunity to strengthen our governance arrangements? So, for example, we look at maternity service, but alongside that, do we look at what our staff survey is saying about a particular place? Do we look at what our workforce race equality standard is saying about that service? Do we ever look at the complaints? Do we look at how we've engaged communities and what they've said about that particular place to give us a rich picture of it? Because I think sometimes what we do, we look at things in isolation. We look at workforce issues over here, and then we look at services over here. And I think there's a real opportunity going forward to join those dots up and say, right, okay, well, what's the problem behind the problem? And how do we collectively sort of come up with solutions? And I think a lot has been said today linked to this point is about informing communities, but I think there's a massive opportunity with strategic commissioning about involving communities in understanding the needs, understanding the gaps, and not only that being part of the solution, co-producing, designing services together. So I know we've sort of considered this in developing the model, but it is worth another challenge look, that is that strong enough in this new sort of way of working.
I think it's a really good challenge. I mean, I would anticipate that, the patient-led assessment of care environments in all our providers, the quality assessments in all of our providers that use the CQC framework as the basis and are done regularly and reported onto the board, the triangulation of the complaints, the workforce, the PALs, the incident reports that we do through quality and system quality group, etc., are in place. Do we get sufficient stock take of those things to say, well, we're assured about that, or not, and who do we rely on as a strategic commissioner to get that assurance? I think will be really critical questions in the future. We shouldn't overlook the amount of mechanisms that there are on this. I think that triangulation point is always important. And I think finding ways to strengthen the intelligence coming in to the triangulation is always something we should be asking ourselves about. So are there better ways of finding out what people are saying about something, particularly in the era of large language models and so on, to help alongside the other mechanisms that we've got. So I do think as we go through this period of change and we think about our role in quality, we should keep coming back to that question and challenge, actually, Majid.
Thank you, Rob. Beth?
Thanks, Chair. So I feel that as the chair of the local midwifery and neonatal system and the SRO as well for West Yorkshire, I just want to point out we have 25,000 births on average in West Yorkshire every year. The vast majority of care is safe and of a good standard, and we get some really positive feedback from families. However, we know there's a variation of quality across the country in different units, and we are hopeful that this newly announced review will help to address that and hope that everyone gets a safe service, because I cannot imagine the heartbreak of families that go home with empty car seats. I think that we also need to acknowledge that in West Yorkshire we do have some outstanding services in neonates. And whilst the future of the LNMS is unknown in the new architecture, I think that our board are committed to involving service users through the MVP as long as we can to ensure that the voices of our women and families are represented and that we can work with them to help to improve services. I think the last point I need to raise is around Leeds, because that's been mentioned a couple of times. Leeds is currently, actually, as we speak, their quality improvement group is ongoing. That's chaired by the region. It's got wide membership from across the country, including national leads in maternity, the national chief midwifery officer, and also the national neonatal lead. And there are really detailed work streams involving families, that involve families in all of those work streams to aim to improve these services. Thanks, Chair.
Thank you, Bev. I think what you said about empty car seats really hits home, and I think that's something we have to keep in mind to ensure that our services have to get better and will get better. Thank you. Any other points, questions to raise? No? Okay, thank you for the report, Rob. We note the changes and I think the increase in business and financial risks for us as an organisation and a system currently and going forward. and also that we note we're entering a transitional period now, which could take up to 18 months before it concludes. And that finally during this period we've just got to have that clarity of direction and hopefully demonstrate the right leadership to take our organisation and our people forward, and at the same time make sure that all our services are the best they possibly can be for our people. So thank you for that, Rob, and everything that you do for us as well. You'll be pleased to know that we're going to go ahead for a slightly early break for 15 minutes and come back at about 10 to 3. Okay, thank you very much.